there, my name's John Blair. I'm the Clinical Director for Geriatric Medicine here at Warwick Hospital, and I'm joined by my colleague
Dr. Reid, one of the geriatricians, basically.
And we're going to talk a little bit today about our service in general, but also specifically relating it to same-day emergency care. So I thought we'd maybe just start, James, given the significant role you played in designing and implementing the service, if maybe you could start by telling us what kind of journey we've been on as a department here at Warwick.
So essentially, I started here about 2013, and so things were developing slowly at that period of time. Then about 2016 we started a lot of lean modelling. So we developed something called the Over 75s Flow Project, and that's where we brought all the different team members together, so different therapists, different departments, different stakeholders, and then that sort of accelerated our development of frailty services. So we evolved things through a PDSA methodology, so we've studied things that we think need to be improved. We've then gone through sort of robust PDSA methodology, got data, and then we've implemented each change at each step. So since about 2016 we've developed probably about 4 or 5 different changes, sort of robust changes which have then been invested in by the Trust. So things, for example, things we've done is we've developed a frailty assessment area, which is a bespoke area attached to a single nuclear footprint, which enables us to provide a variety of services, such as same-day emergency services. We can bring in people from A&E, we can bring in people from GPs. So it's about just developing things. Most of the stuff's fairly pragmatic. It's about solving real-life problems based on what you see around you. And then we just invested. So over the years we've invested in new consultants, new teams, new infrastructure. So we're now in a situation where we've got a fantastic team. We've got a fantastic footprint, got a lot of support from the Trust. We've now made bridges into the community. So the next bit is our sort of footprint in the community and developing sort of whole integrated service.
So the form that the platform that our ECIST service currently operates from is our frailty assessment area, as you've mentioned. So that's a service that we provide within the hospital, currently 5 days a week, for 12 hours a day, 8 till 8. And as you've mentioned, we take referrals from a variety of different sources, and we are also lucky enough to have an acute frailty ward base that's attached to that, so we see our patients and move them to our wards. We take roughly between 10 to 20 patients a day, and all of our data suggests that we get around about a 40% discharge rate from our frailty assessment area. The area that we have is fully kitted out to be able to take all types of patients. So we take a lot of frail patients, but we don't have any limits really on how sick our patients are. So it means that we have a good impact on the general medical take in terms of the older patients coming to the hospital. We're able to take sick patients and really make a dent in terms of the numbers that are being moved to acute medicine. So that's one of the things I think is essential in any older adult frailty service. It also means that we get any data that we're getting from our service is kind of quite reflective of the whole population of older patients coming to hospital. You mentioned our co-located teams, and that was one of our PDSA cycles in the past, where we found that actually it's really important to have therapists working alongside us within our frailty assessment area. That co-located team, so the pit stop style assessment of older people, really works well to improve the comprehensive nature of the assessment they get, and therefore it's almost like front loading their admissions. So we know what they're like. We have a decent plan, and it leads to shorter length of stay, so increased 1 and 2 day length of stay. So we may not get them out on the first day, but the plan's really clear, and if they move through onto one of our wards, then that continuity means that we can we improve the hit rate for discharge on days 1 and 2. So those are the kind of some of the key lessons. Is there anything else you think we need to talk about in terms of some of the key lessons of how we operate our
flexibility, being open, being flexible, having open access, so having anybody contact us, GPs, whether it's practice nurses, just having ownership of the people that you're looking after, whether they're in the hospital, whether in the community, and being open to sort of change. So working with GPs, working with different people in the community. So the virtual wards provided a new stepping stone to sort of be able to provide things close to home, which is where we want to be in the future.
Yeah, so that was the next evolution of our service. So we've so since 2021 we've been operating a virtual ward for frail older adults. So that consists of a virtual MDT that takes place in the morning together with the hospital-based geriatricians and our community advanced clinical practitioners. So we're lucky enough to be an integrated trust with responsibility for community services. So our community urgent response team, consisting of clinical practitioners and advanced clinical practitioners, is part of the trust, and they see patients and work closely with us through the virtual ward. So in the morning we'll meet virtually and discuss patients that have been seen the previous day or patients that are already on our books, and essentially the patients that we decide to admit to the virtual ward are patients that are either early supported discharge from the hospital, so patients going home before they normally would with improved monitoring in the community, or mission avoidance patients, so patients seen within the community and then stepped up onto our virtual ward. So the expectation is these patients would normally be in a hospital bed. They're unwell enough to be in hospital, but that we're using the virtual ward as a way of monitoring them at home. So that's been something we've been doing for the last 2 years, and is certainly something that we feel has great potential. Obviously, as you mentioned before, data is really important, and that's something that that has been quite challenging to collect, given the straddle between hospital and community, and also the different computer systems that we use. But yeah, we've got quite a few things that maybe we'll talk about at the end in terms of the future and how we're developing that. So the virtual ward has also acted as a platform to allow us to work very closely with the West Midlands Ambulance Service. I don't know if you maybe want to talk a little bit about our mission avoidance work with West Midlands Ambulance Service.
Since our last project, which was probably 12 months plus ago, we've been trying to work with the West Midlands Ambulance Service. It's actually been going on for more than 2 years. We know that the majority of the people we see come in through ambulance, so probably the key thing is we don't really want people with frailty turning up at the hospital doors. We want to be managing them in the community, and we want to manage them as early as possible in their journey. So we don't be seeing them 2-3 days down the line after they start becoming poorly. We want to be seeing them on day 1 and day 2, when it's much easier to halt the deterioration in their sort of physical and the medical problems. So that's probably the key thing. When we first started out doing the mandating of calls and getting YMAS to phone us on all patients over 75, we had a lot of success, saw huge numbers of calls coming through. And we managed to avoid 50% of those people coming into the hospital, and they were managed through the virtual ward. Things since then have been fluctuating a little bit. We're starting to see numbers creeping up again, and it makes a huge difference. We're just avoiding people turning up at the hospital. We're managing them in the community, and then the virtual ward and the FAA gives us that ability to be flexible, to bring people back electively in good time, to do further investigations. If we need to step them up, then it's very useful, as you mentioned earlier. Yeah. So that's the real cornerstone of everything. It links everything together. The virtual ward gives our footprint in the community, but the actual FAA and the ESTEC area, the ability to do hot clinic slots, gives that flexibility to manage all different scenarios.
So our mission avoidance work with the West Midlands Ambulance Service is a service that we currently provide 8 till 8 Monday to Friday, that uses a communication tool called Consultant Connect, which essentially allows crews on site with a patient to call directly to a consultant geriatrician for advice. Our criteria, which is included in the Directory of Services for the West Midlands Ambulance Service, is very open. As you said at the beginning, it's about having as many conversations as possible, building that relationship. So I think our criteria is anyone over the age of 75 with an appropriate postcode, or anyone under 75 who has features of frailty, and so we leave it pretty broad. And so essentially what we get is a phone call from the crews who've assessed the patient, and they want to discuss whether or not there's an alternative for conveyance to the emergency department. So we've got lots of different options that we can provide. That we can provide a same-day visit from our community urgent response team, so that's an advanced clinical practitioner. We bring people back for hot clinics, so it might be like the next day or the day after.
Maybe the same day.
Or same day even. So there's that idea of stepping them up to our frailty assessment area as a platform to manage these patients and avoiding emergency department. We can bring them direct to the frailty assessment area for assessment, so the ambulance crews can drop off direct. Or we can advise them for alternatives at home, so they could just give them some advice, discharge on the scene, or back to their general practitioner, or referral on to other community services. So there's quite a lot of options, and as you mentioned, we're getting about 50% conveyance avoidance rate, and of those who are conveyed, you know, a good number of them are brought direct to our frailty assessment area, and so therefore avoid being seen in ED. So that's also better for the patient and also better for the hospital in terms of how flow works. And as you mentioned, brings them to a senior decision maker specialist team quicker. Yeah, so we start to reduce those kind of length of stays and all the hospital acquired complications that we regularly see in frail older adults and extend admission times. So that's been very successful. So I mean, those are the kind of three pillars of what we're trying to do with our SDEC area. The West Midlands Ambulance Service work, we're getting around 100 calls a month. We potentially, some of our work has potentially been has calculated that we could be having about 400 calls a month in working hours for over 75.
We were doing 120. We were doing 120 over the PDSA cycle, weren't we? So that was when it was fully ramped up.
Yeah,
so we could be doing.
So I mean, we got. I think the month when we did the PDSA was March last year. We got about 200. So we got about close to 50% of the potential patients that we could have through the service. So there's work to be done there in terms of building that relationship, and I suppose that's part of the next step. So you talked about mandating calls with West Midlands Ambulance Service. So I mean, I think we've been working to build that relationship. One of the things that we're doing with the West Midlands Ambulance Service is we're going to be introducing twice daily consultant geriatrician input into a virtual meeting with the ambulance service to kind of review the jobs that are on their list of calls, so their stack as it's called, to see whether or not we can find alternatives to conveyance for those jobs. And we're also going to very soon be having a system whereby West Midlands Ambulance Service can push kind of lower category calls through to our community urgent response team, and they will take the responsibility for reviewing that patient and see those patients potentially in a more timely manner, but also potentially hopefully avoiding conveyance. So I mean, I think one of the things that I always try and stress when talking about admission avoidance work is not about avoiding hospital at all costs with the patient. It's about making the decision with the patient to make sure they get to the right place at the right time and see the right person, get the right care. And I suppose, I mean, my experience with those calls is that we're getting a lot of kind of joint decision making with patients. I'm often having a three-way conversation with crew, consultant, potentially, and the patient or relatives, trying to make those decisions. So just to say that we're not trying to avoid all admissions, it's the appropriate admissions. So yeah, we're going to be pushing non-urgent calls through to our community team. And then that's part of kind of the broader strategy, so in terms of our future. So I think we started talking about less beds and maybe a switch to care at home.
Yep.
So maybe you could talk about frailty in the context of, SDEC in the context of frailty in the future vision. Is there anything else you wanted to mention about that, James?
So ideally, sort of expanding our community virtual ward bed base. So a lot of people should be managed at home. We should be getting it much earlier, which goes back to your category 3 and 4 things you mentioned earlier. So we need to slightly enhance our infrastructure a tiny bit in terms of antibiotics and fluids. Our team's already sort of well established. We've got the infrastructure in place. So we really want to be in a position where we're much more proactive in our care. So rather than crisis management, we're moving into robust advanced care plans, where people have clear escalation plans so they deteriorate, clear points of contact, and the ability to offer what we can offer, which is secondary care expertise, closer to home. So we've got a lot of the bits in place. We've got bridges with GPs now. Lots of GPs are contacting us directly through Consult and Connect, and it's just about sort of carefully sort of nurturing those relationships and getting in a position where we can actually, you know, deliver a lot of what we deliver in hospital earlier out in the community, with the FAA, Frailty Assessment Area, is there as a sort of flexible device for us to then step up and step down as we need to. So I think that's where we need to be.